was great. Actually, had we changed slides, we would have said the same thing about many of these issues. So, can I have my...
You need a second?
Well, maybe you can just give my talk.
Maybe not. I'll just take questions. Can I have Dr. Mack's first slide up again, and we'll just take it from the top? So, I think that these are incredibly important issues around the room, because in this room we have surgeons, electrophysiologists, interventional cardiologists, we have nursing people, we have administrators, we have industry. Industry is an incredibly important partner in this process. We will be joined by regulatory agencies, which are incredibly important. And I can give Dr. Horton's slides too. That would be okay. if we want to do that. But I think that Michael's comments wind up being incredibly important and germane. Can I have the advance? Left click? No. So, I don't know that this is a debate so much as it is a sort of an all-embracing concept of what we should do going forward. So the things we're going to address are who and went, where we went, what, and then in whom. We have all gathered around the left atrial appendage. We have interventional cardiologists, we have cardiovascular surgeons, and we have then interventional electrophysiologists. This is a wonderful slide about Dr. Michael Mack. Surgeon is a medical man who can cut but doesn't think very much. I thought that was a great slide. This slide is about Dr. Horton. An electrophysiologist is a medical man who makes burns upside down the road. Some of the time he misses, and there's like a gap on the right-hand side where he missed. And so then they come back for a second procedure, which is really part of the first procedure, which is really not a second procedure, but it's sort of procedure 1A. Who never really sees patients but only understands squiggly lines. And then you have somebody who puts his finger in a dike in a hole like this. An interventional cardiologist thinks, understands, actually interacts with patients and takes care of them, but only some of the time. And so all of us working together may make a difference. What are we going to need to be in this space? We're going to need knowledge of the disease, procedural expertise, how to access the left atrial appendage, either transeptally or pericardially or in combination or with thoracotomy. We're going to need how to recognize complications early and how to treat those complications both early as well as late. And so these are the needs that we will need to work together as a team. As you look through this list, it is apparent, or at least it's apparent, that there are very few people that keep all of those specific skills together in the same body, in the same mind, in the same scrub suit. And so we're going to then need to expand the team care approach. The first piece of information is those things that we need to know. Well, Nancy always had thick ankles, but no one really noticed. One of the problems along a journey like this is we get rolling and we say atrial fibrillation, we got to do something about it, and forget the fact that sometimes Nancy not only has big hair, but she has thick ankles, and the patient has intracerebral disease for stroke as well as atrial fibrillation, or has a hypercoagulable state as well as atrial fibrillation. And so we need to know that. Who's ever in this space needs to know that, working together. We've seen this a gazillion times, and so I'm not going to talk about it other than to say we need to know the knowledge about where left atrial appendage thrombi could go and where stroke comes in the setting of left atrial appendage. We know that now we need to know more about the left atrial appendage as the source of atrial fibrillation. Most interventional cardiologists wouldn't have a clue what that means, and I think that is true. We need to know that. And then who's ever in that field needs to know about CHADS-2 or needs to know about CHADS-2-VASC. Are they different? We talk about them. Are they different? Is there one that is better than the other? Well, there is, at least in terms of the lower risk patient groups. And then we need to know other pieces of information. We need to know about the relationship between has bled and Chad's too Vask. Need to know that. That's part of the lexicon that we must be familiar with if we want to be in this space. We need to know then about the anatomy that we're going to potentially be treating, and these are the same sort of things, whether it be a cactus or whether it be a windsock or whether it be a chicken wing or a chicken bone or whatever it is, and how to image it. So we're going to need to know that. But as we build upon these different pieces of information, it's apparent that it is going to be a team-based approach, because one person is not going to know all of those things. And as we try to optimize care, we're going to need to figure that out. What do we need to know? We need to know how to access the left atrial appendage and how to recognize complications and how to treat complications. Michael talked about some of the courses in transeptal, and then he went back to his institution, and the electrophysiologist then proctored him on those things, and they worked together. In the past, transeptals were just done by interventional cardiologists. The first series of transeptals actually were part of the NIH from the 1950s. Cardiovascular surgeon Gene Brownwald and Ross published 900 patients with transeptal sort of procedures. We're going to need to know about guidance, and so we're going to need to have the imaging people involved, the real expert imaging people. Some electrophysiologists are really expert. Sam Asservathan that talked to you yesterday is really expert. You could take whatever he says to the bank. Not everybody is as good as that. We're going to need to have people who are as good as that. We're going to need to know about how to treat complications, and we talked about that earlier this morning, how to get out of trouble, what Plan B is going to look like. And then we're going to need to know about transpericardial complications, RV entry, LV entry, phrenic nerve injury, pericarditis, different types of abdominal cavity injury, whether that be the gastroepiploic vessel. I'm not even sure where that is in a Netter diagram. But you better know things about it, and electrophysiologists know that because they have been there some of the time. And so we need to know these pieces of information. And then we need to manage complications. And so we're going to have cases like this in the catheterization laboratory where we're in the left atrium, and all of a sudden your imaging person says, gee whiz, it looks like there could be a problem here. And maybe it's because you didn't know how to use a sheath. Maybe you didn't know about continuous flushing. You didn't know about undersized catheters. You didn't know about whether you needed in patients on one of the new apixaban-like drugs that you're going to have to bridge with heparin, that you needed to do that and be able to get access in a patient who's fully heparinized. And so you see something like this, and all of a sudden you're saying, gosh, this is a problem. I need Plan B. And so you're then going to then identify that there's thrombus. This happened to be during an atrial fibrillation ablation case of Paul Friedman. And then you're going to take something like this out and you're going to say, gosh, that's a problem. But we as a team approach can manage that better than any of us alone in this specific space. Then what are we going to need to know about post-treatment and the immediate management, as well as about treatment of continued leak? We've heard about all of these things, but as you have put those pictures, those pieces of the picture together, it comes out being spelled as TEAM. This is a team. Better be a team or it doesn't work. This is a great slide. Clearly you can pull by yourself. You can move things along. It's never going to be as good as the Budweiser horses or whoever those horses are, because they're going to pull more, they will pull better, and they will utilize their different strengths accordingly to reach whatever goal you're looking for. The final piece of information is to say atrial fibrillation is a sandbox. A lot of different people play in the sandbox. In the sandbox, you have to have rules. You have to play together. Not everybody gets all the sand. You can't throw sand either, because otherwise it gets ugly. And so we're going to have to then approach this as a team. And the last slide that Michael put up in terms of the rotating spokes about a service line approach is going to be that approach that wins. It's going to win early, it's going to win late, and it's going to win for your patients most of all. Thank you.